room has slowed down. Well, good morning, everybody. I am Hema Sarang-Saminsky. I use she and they pronouns, and I'm the executive director of Jane Doe Inc., the Massachusetts Coalition Against Sexual Assault and Domestic Violence. And so excited to be here this morning with the incredible team from the DCF DV Unit, along with many folks in this space who have participated in one way or another in our months long process and set of convenings related to really looking at the issue of survivors and children at the intersections of domestic violence and sexual assault, and what happens when there is the possibility of a DCF system involvement. How do you navigate some of those tricky situations around safety and healing and safety and state involvement? And what helps in those scenarios? What are some of the barriers that folks have experienced in those journeys? Um, we dove into questions of, we talk so much about mandatory reporting and questions about mandatory reporting. But as we sat together in a community of practice over six months, there was a dedicated group of about 15 to 20 of you all who shared your time with one another to get into the nitty gritty of what it means to be a provider, and navigate some of these situations with survivors in all towards, how do we minimize harm and how do we maximize the ways of keeping community and connection and support available to survivors, to families who need it the most. So that was really the purpose and kind of orientation of those several months. There were a few key takeaways. First, there's a lot of creativity among our membership. There many programs are actually, the bulk of mandatory reports don't come from programs. And I think our DCF DV unit can speak to that as we talk through have this conversation today. And
Mes.
when those situations
Sí,
do
ya me
come,
llegó, gracias. Ok, papá. Gracias.
there we go. When those situations do come up, they can cause a lot of anguish for an advocate, for a survivor, for a program. And we really set forth over the course of 6 or so months with the futures team, as well as a consultant who specializes in restorative practices, to really set the values of how we want to move as a field. How do we want to really embody values that are core to restorative and transformative justice? Meaning, how do we build community and how do we stay connected, and ensure that resources and safety and healing are available to all involved in that particular circumstance and situation. So that was we did some journeying, we did some journaling, we did some story sharing, and at the end of our time together, there were many questions that arose that were really centered on the space of, okay, so what are the next steps? Sometimes when we're in crisis, we're working with a survivor, we're on the phone with the social worker who might be involved with a particular survivor. It feels like we are at odds when ultimately, hopefully, we all have the same goals. and what are the possibilities of moving towards um, more collaboration in ways that are actually aligned in some of those values of safety and healing and keeping families together in the way that they want to be, right? And that's really some of where we left off. And I remember one community practice member saying, well, we can't do this without talking to DCF. And we need to have those conversations. And I'm so grateful for Sue Hubert, for your leadership, for so many years in this area and in this field, through many amazing conversations over the past couple months. We came to a hey, let's have a chat with a small group of folks. And then 87 of you signed up for this small group chat, which I love. And we are so grateful to have Sue English Lashpetz and Michiko Kita from the DCF DV Unit with us today as well. I will let everybody introduce themselves. But just wanted to share a bit of the context of how we came to be here. While this is going to be in a kind of a fireside chat panel style conversation, we know that there are folks in this room who gave up a lot of their time to be part of that community of practice and really, really invite you or anyone else to throw your questions into the chat. We'll try to make it interactive. We'll put out questions to you all and really, really welcome your insights, your directions around collaboration and possibility, and bring that wisdom that you really shared with all of us over the past many months. I think one in preparing for this conversation, one framing that we landed on was this is a really, really hard time for so many communities at the intersections of oppression. And as we sit in a time period where people are being disappeared off the streets, where trans communities are under profound attack, where communities of color are being even more policed than they have been, you know, to the extent that we can build relationships with partners like the DCF DV unit, uh, if we can work well together and build some trust and alignment, it can minimize harm all across the board and also realistically minimize the overwork that I think each of us, all of us, can really speak to in this time of shrinking budgets, expanding need, and just really overall exhaustion. So there's a hopeful side of how we can work well and collaboratively together to reduce the harm in our communities. And so with that long introduction, I am grateful to welcome our guests here, and we'll pass it to Sue and her team to introduce themselves, and then we'll jump into some questions.
Sure. So thank you to you, Hema, and to everybody who's taken the time to make the time today to chat with us. I couldn't agree more, Hema, as this is more than ever a time to come together in the places that we hold similar in how we want to support families, because there is so much happening bad out in the world. And it's been a pleasure getting to know Hema specifically a lot more over the last year. So that has been really, really fun for me. I am Sue Hubert. I'm the director of the Domestic Violence Unit. Next month, I will have been at DCF in the DV unit for 31 years. Never had the intention of staying that long. And prior to that, I spent about 10 years in domestic violence shelters doing that work. So I'm going to just tell you a couple of pieces of sort of what my role is, and I'll pass it off to Michiko and Sue. Um, One of my major roles is to support Michiko and Sue as they supervise our staff. We've got a staff of 11 specialists across the state, and Sue and Michiko supervise them. Um, so part of what we're doing together is making sure that our approach and teaching and focus for the agency has consistency across the state so that, a worker in Pittsfield is going to get similar, if not the same information from staff as they would in Boston. We develop trainings together, sort of guidance for staff and how we approach, doing our consults. In my role as a director, though, I'm also a senior manager in the agency, so I have responsibilities that are beyond just managing the DV unit. I sit on the agency priority initiatives. I'm on the racial equity and inclusion group for the agency. So there's a whole bunch of other things that get put on my plate, much to Michiko and Sue's dismay. Um, yeah, so that's me real quick. So Michiko, why don't I pass it off to you?
Hi everyone, I'm very excited to be here. So my name is Michiko Kita. I use she, her pronouns, and I'm a supervisor at the Domestic Violence Unit. I have been at the department for 12 years now, and I supervise 6 DV specialists, so 3 in Northern region, 2 in Southern region, and one cross-regional specialist who covers Boston and the Southern region. I have been working in the DV field for about 25 years. And before my current role, I was DCF DV specialist for Boston region. And then before that, I worked at 2 DV programs in the greater Boston areas. So I was just thinking about to preparing for this meeting. I wanted to share that my experience working collaboratively with DCF and other DV and sexual assault providers really supported my core missions to really strengthening the collaboration on behalf of survivors. So I think we can talk a little bit about who we are, but all of us have worked in the DV field, and that really helps us to continue that collaborations. And we have been serving as a bridge to support the partnership and continuing to build those connections. And that remains my ongoing goals in my positions at the DCF DV Unit. So thank you so much for having us. And I'm gonna pass it to my other half, Sue English.
Thank you, Michiko. Hi, everyone. My name is Sue English Lockwitz. I'm a supervisor in the Domestic Violence Unit. So I have been with the agency for, actually in September, it was 25 years. So I came right into the DV unit as a specialist out in the western part of the state. And then for about 11-ish years, I've been now supervising. Prior to coming to DCF, I worked in the domestic violence community. I was in the shelter system. And I think for me, that's really what has grounded my work with advocacy for families. And I worked in shelters, then kind of worked in the criminal justice system, and then felt like I really needed to be working with the whole family. And so I've brought that advocacy work into my work here within DCF. So I'm excited to be a part of this. And as Michiko said, we really work very hard making sure that we stay connected to the DV communities because we can't do this alone. So I'm glad to be a part of today as well. So thank you.
Thank you all so much. So just to kick off some of the logistics around the agency and the relationship between the DCF DV unit and the rest of the agency. I think sometimes when we talk to providers who have had interactions with a particular survivor working with a particular caseworker, it's almost like there are many layers of interactions that could be happening. So it would be really helpful for you all to paint a picture of the structure and relationship between your small team and this much larger agency in which you sit, and how they all work together.
So Sue, Michiko, I'll do a little broad stroke and then you guys can fill in. So one thing to know, when the DV unit started, which was back in the early 90s, we were the only specialty unit in the agency for a long, long time. But over time, the agency saw the advantage of having folks internally to support the DCF office staff, and we now have a whole host of specialty units. We mostly interact with how we would call the clinical units, which is there's a mental health unit, a substance use unit, disabilities unit, an LGBTQIA unit. Those are the closest ones that we work with, although we also have a housing unit and an adolescent unit and, several different other units that we've got for the agency. Those clinical units are all structured the same way that we are, which is there's a director. Not all of them are staffed equally. Some actually have more staff than us, some have less. So not all of the units have supervisors like we do with Sue and Michiko. And the specialists are all based and responsible for supporting specific regions and offices within that region. So, for example, I have regular contact with all of the directors. We meet at least 3 times a month. So we're all in collaboration. Sue, Michiko, and the regional specialists have regular contact and know the other clinical specialists that are in each of their regions. And it is not infrequent that they do joint consults, because if anybody knows anything about DCF, it is actually infrequent that we are involved with a family where there's not more than one issue that they're struggling with, right? So we frequently will do joint consults with the mental health and substance use units and their staff. So there's a lot of internal collaboration on how we help the staff in the field. When I talk about the area offices, I'll just lay out a quick picture of that. So the agency has got 29 area offices across the state. Each of those areas are designated within a particular region. So there are 5 regions identified across the state. So there's a regional office, and let's say for the West, there's a regional office, and there are 5 area offices. And then our staff hold, responsibility for specific offices as well as working within the region. One of the things for folks to know, I think specific to how we help staff, is the biggest way that we do our jobs is to do consultations with social workers, their supervisors, and sometimes managers of offices on individual cases. We also do trainings and clinical reviews, but the bulk of our work is in those specific consultations on individual families. And part of what we do in there is to try to help think about not only the assessment of risk, but giving the area office staff strategies and techniques about how they interact with that family and to do it safely. We, just as a point of order, I'll say this, and many of you may know this, but we do not do direct service with survivors. We want them to connect with you as an advocate. We can't offer them confidentiality. We're state employees in the agency. Even though all of us have a background in the DV world and know how to support and talk to a survivor, it's actually even more of a reason for us to not have direct interaction with them because they may tell us stuff that we would then have to tell their social worker. So we do our work with the goal of not only helping someone on that specific situation, but also with the lens of teaching so that they can apply it to other cases. So we're trying to exponentially increase the capacity for the agency. And in the offices, I think it's important to note there's a lot of hierarchy in our agency, right? You may be having most direct contact with social workers. They have a supervisor of their unit. That supervisor has an area program manager. The whole office has an area clinical manager, and then there is an area director. And there's many layers in there. So that may come up later when we talk about strategies, but I'm gonna see if Sue and Michiko have other things that I probably forgot or that they want to share.
Just a couple things, Sue, you did a great job. Just a couple things. I think it's important for folks. I know that when I work with providers out in the community, they might call us because they think that we know about a particular domestic violence case. And it's really important for folks to understand that we don't get pulled into every domestic violence case that comes into child welfare. We have approximately over 20,000 families that are open with DCF. Nationally, I think it's 40 to 60% cases involve domestic violence. We run around 50%, so that's like 10,000 cases. So we don't get pulled into all of them, so it's important for folks to know that. Another really important thing, as Sue said, we don't meet directly with families. We're meeting with the social worker, so we're hearing their perspective about the family. We look at cases as, to make sure that we have a lot of information. But we also don't make decisions on cases. So ultimately, the clinical decision on a case is the area office. But we do try to build relationships within our offices so that if we feel that possibly a case is not going, that they're missing some pieces, or we could have a better impact in a different way, we might bump that case up to an area program manager or higher, because we have established these relationships. So if we feel something needs to look a little bit differently, we might, pull in other people to try to get folks to understand from our lens what we might be seeing or they're not seeing. I think the other piece too, we get pulled in throughout the whole case. We could get pulled in the very beginning of a case. We can get pulled when a case closes. We also participate in a lot of regional and area office meetings. And again, I think for us, we always make sure when folks are calling us from the provider, from you guys, that we have releases, and we really try to bridge the gap between us and the area office and really try to get you guys connected. I think that's all I have. Michiko, do you have something?
We are passionate people, so we all have things to say. But so a couple of things I want to add is that when we are doing a consultations or training, we are thinking about the whole family system. So not only the survivor, but we are thinking about the engagement strategies with a person using violence and impact on the kids and how we can support and create the safety. The other thing was how Sue H talked about the different positions within the area office. Decisions making is not one person thing. So there is always supervisor, manager, like everybody needs to approve, and there's a lot of conversation within the area office too. And then I think they value our thoughts, and we will be part of the team. At the same time, just for you to know, many people get involved when especially thinking about the case directions or changes.
Thank you all so much for that. And if I just want to throw this out to all of you watching as well, and everyone in the audience, if there are questions that any of these questions that I'm sharing prompt for you all about how the system operates, about any of the more general procedural pieces, please share that in the chat as well, and we'll try to get to those questions as we go. Okay, so we have a little bit of a background on the structure of your unit within this, and I'd like to kind of pan out to philosophy a bit right now. I know some, actually probably many folks in this space might be familiar with, and others might be newer to the history of the DCF DV unit, and many of the innovations that this unit actually brought into the field of understanding this intersection of survivorship and impact on kids and what happens when what it means to be a survivor of intimate partner harm with kids navigating state interventions. It would be great to speak to that. It's a two-part question. So I'd love to hear a little bit of you all share that history in Massachusetts, and then kind of pivot to present day. We have an incredible commissioner and Commissioner Miller. Really just want to hear a bit more about her approach and perspective around, honestly, the range of questions and critiques about this system, right? As a coalition, as we entered into this work, one of our entry points into this work was looking at, I think, in the events following the murder of George Floyd, and amidst those conversations about the criminalization of survival, about over-policing, many members brought up the reality that, hey, if we're talking about police, shouldn't we also be talking about other systems? Should we be talking about the child welfare system as a whole, as another example of a type of agency that may engage in disproportionate targeting of communities of color, of low-income folks, of communities with disabilities, all of the marginalized communities that we're talking about today. So against that backdrop, this is more than a compound question, you all.
Yeah, it is.
History and present. It'd be great to have you reflect on a little bit of the philosophy of both your unit and the agency as a whole.
Absolutely. I will keep the history and development short. I really like talking about it. So
I like you talking about it. So
it was very intentional and surprisingly back in the late 80s based on data. So in the late 80s, like many systems, large systems, change is often facilitated by crisis, right? And it's not the change that happens from crisis isn't always good, and it needs to be adjusted. So in the late 80s, there was actually a situation where there was a terrible tragedy. A child was killed in a situation where DCF had an open case with the family, had been working with the mother, had no idea that she was in a relationship. We had no idea that there was domestic violence going on, and that it was very much in the media, very much a pronounced thing that was driving the actions of the agency. And from that, DCF at the time, DSS at the time, actually, basically they didn't do a policy, but they basically wrote a white paper that was sent out to all staff, and it was called Project Protect. And in a nutshell, this 12-page document identified that domestic violence was an incredibly high-risk situation for kids. They didn't give clinical support to the field. They didn't give instructions about what to do. They were just like alarms, alarms, alarms. DV is really bad for kids, and we need to make sure we take that into account. After that went out, there was an incredible spike in a couple of things. One, there was a huge spike in reports that came to us based on domestic violence. There was also a big spike in removals of custody, so care and protections that we did in these cases. And at that time, the coalition, which I was actually a member of the coalition board at that time, identified a drop in requests for assistance from survivors. So we took those things, we took those pictures and that data, and the original manager and developer of the unit, Pam Whitney, came with this idea of what if we had a DV advocate or a DV unit in the agency to be able to help with the clinical needs. And it was very much focused on these things that are happening aren't the answers to helping families be safe. We're having a knee-jerk reaction, and what the staff need is support around how to do their work differently. So that's the origination of the development of the unit. For a couple of years, there was one person. They collected enough data with the manager who helped develop it to make an argument for the further development of our unit, and that's when we started getting staff expanded. And I think that the other historical thing to note is that I was hired. There was a first wave of like 4 additional people hired, and I was in the second wave in 1994. And when I was hired, and it had been this way for the other folks that were in the unit up until I was hired, we were absolutely not welcome in this agency. I literally sat for months in different area offices and in regional offices with no one talking to me. I would bring food in. I developed my most basic relationship building skills at that time. Like I would do anything to try to be helpful. And for me personally, that broke open when one supervisor in one unit in one office reached out for me for help. And it was actually in a response unit, our investigation unit. And we worked really, really closely, and that shifted everything because the staff in that unit and that supervisor found what I had to offer helpful, and that traveled throughout the office, right? Throughout the course of this whole time I've been here, there have been, incremental steps, right? That didn't happen the same time for everyone else in the unit that did for me. But over time, with more staff, with developing our skills around really needing to become a hybrid, right? I came in as a domestic violence advocate. I am now a specialist in domestic violence in a child welfare agency. So we had to become child welfare workers. And part of why that was important is, number one, in order to figure out how to overlay domestic violence practice and thinking into child welfare, I had to really understand child welfare and what staff here deal with on a daily basis. So I learned from them. And then we had to take this domestic violence practice that we knew and turn it into, how do I say this? It needed to become concrete things that workers could take the next day into a family's home that they're dealing with. So it couldn't be just like, here's the dynamics of domestic violence. It needed to be, the backdrop is, here's the dynamics, and here's what this means to your daily work. And quite frankly, that work that we do in sort of combining those things has been an ever-evolving thing the entire 31 years I've been here. We had practice guidance back when I was an early specialist, and we have practice guidance now that is very different. It has some, of the basics still in there, but it's much more evolved. And also during that course of time, we transitioned from primarily focusing on how do DCF staff interact with the survivor to how do they interact with the survivor and how do we understand impact on kids? And then a little bit later, understanding that we had to integrate the idea of needing to engage with the person using violence in a much different way than DCF ever had. This is a person, we have a lot of intact families, meaning the couple is together with concerns of domestic violence. And if we don't effectively and safely engage that person who's using violence, none of what we're doing is going to make a difference. So that has also been a journey for us to make sure that we're all educated on that and thinking creatively about it. So that's a short history. Sue and Michiko, did I miss anything that you're aware of?
No, I always enjoy listening to you tell the history as well.
I could talk about it for 2 hours.
I know you could talk it. And she also has a lot of pictures of the timelines of everything. Yeah.
I think some big thing that we have been putting more focus with, especially with the leadership in the last few commissioner, is to really thinking about the racial equity work, and Sue is a big part of that. She talked about it, and then for our unit in the training, we have been having some time to talk about the confirmation and the implicit biases and how that plays into the decisions making or strategies working with the family kind of thing. So those are kind of the things that we have been putting and efforts and including in a consultation, not only with the training, paying attention to that in the last few years. And I think we would continue doing that as well.
Racial equity and the idea of bias has been sort of a cornerstone of the unit from when I came in. That's really where I started deepening my learning. The one other thing that I want to add, because I said at the beginning, like I was not welcome, none of us were, that has dramatically changed. And it grew over time with individual offices and staff, but it really went leaps and bounds when Commissioner Linda Spears came in 2015. She left 2 years ago, and Commissioner Miller is our commissioner now, but she has continued it. When Commissioner Spears came in, she did things like she brought me at the time. I was the only director. We've developed the other programs since then, but had all of the directors of the clinical units going to our statewide managers meetings, which is all the area directors, all the regional directors, and all the senior staff. We were never invited to that before. We are deeply valued members of the clinical teams across the board, from specialists being in clinical review teams and offices to I sit on the central office critical incident review team and have regular contact with the commissioners and senior staff. Like our value has been concretized in our presence in all of these places. So it's a very, very different landscape for us to be able to have some influence in a lot of different places.
Thank you all. Just to close out that question with one more portion of that long compound question, could you, to what Michiko, what you started naming, how would you say, like, with the current questions and concerns around disproportionality, over reporting, those types of concerns, how would you frame this, Commissioner Miller's approach to this? Going to be really helpful as we then move to the on the ground kind of realities and how to move forward.
Yeah. So I'll say a couple of things in general. One is, it is without a doubt that the reports that come into DCF have a lot of disproportionality in it. The good news is that after they come in, disproportionality is not increased into the life of a case. Like, we aren't screening more families of color in than other families. Cases aren't, I'll say this. There's some deeper dives we need to do on some of the data, but basically the first sort of ground message is the disproportionality isn't being increased after the front door as it comes in. It's unfortunately sort of staying as it comes in. So that's something we want to work on. The issues around racial equity and inclusion, disproportionality are all things that we, as an agency, not just the DV unit, talk regularly about. So there's that. Commissioner Miller, I get started with Commissioner Spears too, but Commissioner Miller is vocalizing and really committed to trying to move DCF into a place where we're really only involved in families who are experiencing the highest levels of risk. Moving an agency this big is a big task. But they really, one example of this, one thing that is sort of a concrete noticing factor, we get reports from folks that are so clearly an accident. And I'm not just talking about domestic violence situations, in overall in general with what comes in. Police will report to us a situation if there was some kind of an accident, even though it's so clear that it wasn't about abuse or neglect. And for a long time, it put our screeners in a position of not really being sure what to do, because there's this sense of kind of professional courtesy. Like, if there is a professional reporting to us, it was seen as sort of incumbent upon us to make sure things are okay. That has really changed. And really consciously efforts were made from the commissioner's office down to change that. And Commissioner Spears and currently Commissioner Miller really worked to empower offices to use critical thinking to screen those unnecessary reports out. There's also, over the years, been several changes to our structure and process of bringing in a case, because it used to be that we had to screen in a case and manage an investigation in a very short period of time. I think that before it was recently changed, it was 10 days, and those 10 days included weekends, right? For an investigation, a screening had to happen almost immediately. So it didn't give people time to get a little bit more information or think about it more as a group, or, make these decisions based on more information than just this, 4-sentence report. So that timeline has increased, and they really, really have been supporting offices to, like I said, critically think about screening those unnecessary reports out. We've also increased the ability to take more time to make a screening decision. So before, it had to happen within a few hours. Now, if it's identified at the front door as a non-emergency, meaning we don't have to get out there right now because this child is imminently at risk, we can take up to 5 days to make that screening decision. And that makes a huge difference to be able to really gather information. I'm sorry, not 5 days, 3 business days. that gives us a lot more ability to do things like gather some information from other people, but it also, specific to domestic violence, one of our big mantras for staff is we've got to make safe contact, right? One of the big mistakes child welfare used to do is we'd get a report on DV and we would just show up at the house. And the couple would be there together, we would talk to them together, and it created all kinds of danger. Um, we've got enough time at screening to think more specifically about how to make safe contact. Um, we have an ever-present rolling new staff coming in and out of the agency, so we have to keep teaching that. But we've got the structure that allows staff to do that when they know how to do it. Um, yeah,
Yeah.
I'm gonna leave it there.
Yeah, thank you for that. That's really helpful context. Couple more questions, and then maybe we can move it to the group. But I know Julie, I'm holding your question for one more second to get to the collaboration piece. So since you're talking about, as we're talking about where these reports are coming in and this new approach, one effort that many of us were involved with was the recent promulgation of the law enforcement guidelines. We had some questions, and there were a number of voices in that space who were trying to raise, and appreciation to you, Sue, for being that voice in that space to lift up that kind of critical thinking aspect that is so essential for survivor safety. Unfortunately, in the end, a lot of that nuance fell out of the guidelines themselves. There's this tension that I think many of us experience in this field where unfortunately nuance is not welcomed, even though it is so essential. But I don't want to phrase it quite that way. We hold nuance, and we know that is so essential for survivor safety, for understanding, for being culturally responsive, for really meeting survivors and families where they're at. Given that your agency interfaces with systems like healthcare, like law enforcement, that are making split-second decisions, there's a different type of approach. How do you navigate those tensions, and how would you suggest any words of wisdom for our field as well as we navigate those differences in philosophy, right? I am I'll just, by way of, I am, have had more than one experience of trying to offer more nuance than a reporter, for example, ever wants about an issue. Our communications team will confirm that. But that's a tension there, and it harms. It can create harm.
Yeah, I agree. So I can say a couple of things about that. One is it is sort of across the board, and I think this is probably true for child welfare just about anywhere in the country, but certainly is here. We have the vast majority of our reports get made to us from law enforcement, health care providers in medical field, and schools. Like that is the enormous bulk of where we get reports. And I mentioned earlier that it is not infrequent that we will get reports, especially from police, in situations that are just clearly not abuse or neglect. Part of so there's been some staging in the sense that I talked about earlier of trying to really educate and empower the offices to screen those kinds of things out. There's also a great deal of support for them to outreach to the place that made those kinds of reports. So I will give you for instance, it just happened on Tuesday. On Tuesday mornings, I sit with the central office critical incident report team, and we review all the critical incidents from the week prior. It might be anywhere from 8 to 30 reports. It just depends on the week. And there was just this incident that was reported that was clearly it was actually a car accident. No drugs, no alcohol, no concerns. There was a child in the car, and the police felt the necessity to report to us. So not only did the office screen that out, but they also wrote in their report to the central office team, we're going to be outreaching to the police department to discuss, right? So, and I think it's important to note, at some point, we will end up having a lot of conversation about the importance of relationship building, right? Because that's when you know someone and have built respect for them, you can then have hard conversations that are more productive. Likewise, that goes all the way up the food chain. So some offices have evolved relationships with local hospitals, local police. Others have tried really hard with some of those places, and those places have kept them at a distance. And other offices are not as skilled at even trying to make those relationships. So it's all a work in progress, but we can't go out into the public and say, don't report to us, right? So we've got to be nuanced about it. But some of these places have either policies or at least protocols in place that don't give their staff the option or the opportunity to sort of think independently about it. We also know that there might be a policy saying one thing while the practice is maybe very different, right? So that's sort of the backdrop. We are trying to educate when those things come up. There are some police departments and some hospitals that are bigger offenders than others at doing those kinds of things. And on all different topics, so all of us are involved at different points trying to do that education. As for law enforcement, well, this actually goes for anybody, but it came up specifically about the law enforcement guidelines. So one thing to note, and this may be speaking a little bit to if there's a question later on about, what are the opportunities. But if you haven't recently, go back and read the mandated reporter law. Just the first couple of paragraphs, because we worked really hard to not have a bunch of specific circumstances thrown into that language. For instance, there was a point in time not that long ago that someone wanted to add domestic violence into the mandatory reporting law, and we really worked on and advocated for that not to happen. One of the simplest reasons being is that calling something domestic violence doesn't actually tell us anything about what the risk is to the children. Many people have different definitions of what that is, so it's too sort of an arbitrary phrase. But the law itself says that if it's in your professional capacity, if you have a reasonable cause to believe that a child is suffering physical or emotional injury resulting from abuse or neglect, then as a mandated reporter, you need to file. But that in your professional capacity is a critical statement in there. It's saying to people, you're a professional, you have skills, use that and your judgment to make this decision, because there is no completely black or white situation. So those are the kinds of conversations we try to have when this comes up. Sometimes it's, an engaging conversation. Sometimes people aren't interested in that kind of nuance, even though I don't feel like it's a huge nuance. Like, we can get to nuance and go big on nuance, right? This is not a big nuance. This is a fairly reasonable one. But we probably, like you, all of you, We have had some successes in different places with different professions and have had some, complete blocks with other folks. I think that the law enforcement guidelines does quote the mandated reporting law. It has that language in it, but they didn't include all the language, but they did feel like they needed to include that's two sentences where it says, and if you don't file and there was abuse, you can be fined, right? Or I think there's even jail time associated with it. Just important to note, we have literally never prosecuted anyone on that. It has absolutely never been done. So yeah, I'm not sure how many police officers are going to run out and read those specific guidelines. I actually had a recent conversation with Angela Davis at EOPS and Maura Laudry. And we're going to have more conversations because I think the real opportunity there is to talk to them about what is actually trained versus we can't change anything right now in the guidelines until it's revised again later down the road. But we started a conversation with them about how can we train on some things that might be helpful in these circumstances. So on this particular topic, I may be as frustrated as all of you.
Yeah, thank you. Thank you for that. It does get to the relational piece though, and I think we can use the rest of our time together to really get into some of the collaboration and kind of cultivating that kind of relationship building set of questions. And Julie, actually, I don't know if you're interested or available to unmute and just bring your voice into this mix, but I saw your question about what happens in those moments when you're working with a particular social worker and wanting to offer more encouragement or support to get the big picture. But if you feel like unmuting and sharing your question out loud, you're welcome to, or I can paraphrase.
I can do that.
Great.
Hi, thank you for being here. I have asked this question before. I'll probably ask it again, but I think it's always valuable to surface it and to ask. Given that your team is in a role of consultation, and that most of the rest of us doing work in DV agencies are going to interface with DCF social workers with a wide variety of skills, backgrounds, and perspectives. I would love to hear any guidance you can provide on how we might suggest that a consult would be really helpful to this worker and of course, to the family that we're working with. I hope that's clear.
It is. Sure, Michiko, I've been talking a lot. Do you want to jump in on that, or you want me to start?
I'll jump in real quick, and I know Michiko will jump in as well. So I think for me personally, we work real. I think we've talked about relationships. We really try very hard to build relationships within our area offices. And one of the things that's always helpful is one thing I could suggest to you is at times it can be a little bit easier for us to get pulled into a case if you reach out to us. So, with releases, if you feel you got releases, reach out to your specialist. We'll make, if you don't know your specialist, we'll make sure we get those lists to you guys. But we get called quite a bit from providers saying, look, we're working with this family. This is not making sense to us. Is there any way that you can get pulled into a case? So we can reach out to an area office and get pulled into a case just by you reaching out to us. So if you have, for instance, suggested that this social worker reach out to their specialist and it doesn't seem to happen, definitely reach out to us, and we work really hard about figuring out how to reach out, and be that kind of bridge for you, and more importantly for the family. So I always encourage folks to reach out to us. That's part of why we're here, to help support you guys. And as you said, we have new social workers coming all the time, with varying experience around domestic violence. So, again, I think it's important to know who your specialist is and reach out to us. And then we can help bridge that gap and help the area office, if they're not kind of seeing something that maybe from our lens we might see and is very different. Michiko?
Adding to that, I think the ongoing conversation between you guys and us are very important. So we need to also get feedback too, right? And in that process, we may be able to explain why the DCF does certain things in the process. And I think that's that conversation and continuous of collaboration. But we really want to hear the feedback, and we really gently approach the office and say, like, let's talk about this, like, in a very supportive way. So we would really like to hear from you about any questions or any challenges that you see for the survivors. And as Sue said, we have, we said a couple of times about having a new staff come and go. At the same time, the social worker is not just dealing with a case with DV. There are so many different situations the family face, and I don't know how they manage to try to know like every area of complicating factors, and that's why we have a job to kind of support. So whenever that we feel that we can be supportive to the field or to the provider, we want to do that. Our job is to be really the bridge between the providers and DCF, so we can do a better job on behalf of the survivor. So yeah, I would encourage you guys to contact us.
I think I saw an ask of getting a list of our staff. Did I see that correctly? Yeah, so I'll get that to Hema. We've got an updated list. And I think, I'll say a couple of things about this because it speaks directly to what the question was. If your program doesn't know your DV specialist, like you're not having regular conversations or a recent one, use that list to reach out. You could also reach out to Michiko or Sue to help set something up, because when we're talking about how to really do the best work possible, how to get families what they really need and support survivors and their kids in safety, we do that best when we know each other, we understand each other's not just perspectives, but we have different roles, different mandates. Doesn't mean that we can't find common ground. But all of those things go better, I think, when we've got an ongoing relationship. So if it's been a while, maybe the specialist has changed, maybe some of your staff have changed. Let's do sort of reacquainting and talk about things, because we get from community providers a sense of what's happening in the office. As Sue had mentioned much earlier, by far, we don't touch all of the DV cases in this agency. So if there's a pattern of something happening, we don't know it unless we're in a case or we hear from other people. So we absolutely want to work with you all on that. So we will make sure that you get the staff list. And in our unit meeting next week, we will warn our whole staff that all of you may be reaching out.
Yeah, and I think it goes in the other way too. Like for us, we should also get to know you guys too. Like you may have some changes, and we wanna try to do that because we will be calling you too. Because when we need a support as well, so like that goes on the both way. That I think that connection is gonna be really important.
I mean, and to take this to possibly next step idea level, I mean, one of the things that the coalition can do is to bring folks together, perhaps even around food. And, if there was an opportunity to have programs come together and meet and be in space with you all, with the area directors, with special, like that could be a really lovely way to bridge some of those connections. If that feels like something that folks would be interested in, either in person or if we must virtually, just drop a little note or emoji, and we'll put that into our list of possibilities. Cool.
Well, I think to build real quickly on that, I think that this kind of work begins with us as, knowledgeable about what you all do, and being within the agency and domestic violence focused. But a needed progression is us helping that relationship develop with the office staff, especially with leadership and your programs. Because if we don't do that step, it's just all filtering through us. And that's not the most effective thing, I think. So yes to what you just said.
Yeah, absolutely. I think that's, I guess on that as a segue, this isn't, these conversations, because of turnover in the field, because of, to what I see at one comment here that this might have happened years ago. If there is, if you all have examples of what some successful program and provider DCF collaborations have looked like in the past, it would be great to bring some of those examples into this space. And for those of you who are here listening, if you all have been part of some of those collaborations over time, or have some examples of really great relationship building that have resulted in better outcomes for survivors you're working with, please let's bring that into this space now. So I'll turn it over to you all first to just share any examples that come to mind as the DV unit, and then please feel free to raise your hand, unmute, chime in. Oops, you're on mute.
I'll give one example and see if Sue and Michiko want to throw a couple in. There actually was recently a situation where, it was an incredibly traumatic event that happened for this mother and her two kids. And it ended up that these kids needed sort of some immediate clinical intervention and support. The mom needed, medical support and, emotional support about what just happened. We knew the local program in the area very well. And we were able to call them and say, we know that there's often waiting lists for, a child witness program. We know there's, a lot of stress on staff, but here's the circumstance. We really want to work with you to try to get this family DV specific support, not just a mental health counselor. And it was because of that relationship, they were like 100% on board. Like they made this happen for this family. The family was asking for it. They needed it sort of more critically right then. And I think by having that developed relationship, it's not just that person, but that person and they know that we aren't going to ask for this somewhat sort of not special, but enhanced response. We're not going to do that in every case, right? They know us well enough and the way that we think about things that they can trust in that moment. We're saying this is really critical and we need some help, right? So that's part of what comes out of that relationship that has developed.
I think there are so many situations like this that when you say one, I'm thinking like hundreds, and I'm gonna start having a list of that. But I wanted to touch on about the the mandated reporting things and the exam, I want to use the example. So one particular program reached out to me for consultation about whether they should file or not. So our goal when we get the consult, like this is not to give a simple yes or no answer, but instead we brainstorm together to figure out what information might be helpful together before deciding how to move forward, or if they decide to file, how to file safely. Because not every DV situation requires a 51A, and there are things that the providers can do a lot to avoid DCF involvement as well. So then one day I got contacted by public school support services, like administrator, to discuss how to approach DV-related filing. And they told us that that local program shared the experiences doing a consult with us around the filing, and actually school wanted to talk to us to see how to go about it. And that really reinforced how important it is to think about the broader system. And I know each DV program have such a tight communities and collaboration within that communities. And I think it's important for us to share some best practice and help each other's collaboration to develop thoughtful and also survivor-centered strategies. So I was pleasantly surprised. I was like, why is the school calling me? Like, what's about? I was so mysterious about it. And actually, because of the DB provider, found it very helpful to have those dialogue with us. And I hope that we can do more of that with the different community providers as well.
So as Michiko said, like I could tell you, I'd like have a list, and one of them was going to be a mandated reporter, but so I'll have to change my thought process to something else. But I do feel like, one of the reasons I came into DCF is, I just really wanted to figure out how we could make sure that survivors' voices were heard. So working with the DA's office prior to coming, like I feel relationships are so important, and I think, whenever we are in the middle of a response and it's a pretty significant DV incident, we generally reach out to the DA's office to make sure that we have another system that's holding the person that's using violence accountable. So for me, when I make those connections, it's really about then slowing down our process, knowing that this person is being held or being detained, or what, like there's some safety, so that we then with DCF then can slow our process down and really make sure we're supporting the survivor and the children. So I don't have like a specific example, but we do often work really closely, especially during our response, with the DA's office to make sure that we can then slow our process down so that we know that the kids and the survivors are safe. But again, I think, as Michiko said, we do get calls sometimes around filing, and although we can't tell them yes or no, we help them to think about, let's talk about all the things that the survivor has done to create safety, what might be some barriers as to why they haven't done certain things, and making sure that they always file on the person using violence and not the survivor. So I think we could come up with a lot of examples, but I'd also love to hear from folks in the room too, around, because I know there are folks in here that we have collaborated with. And so I always would love to hear from folks other than us too.
Yeah, so feel free to raise your hand, just come off mute.
Oh, Sue English. Carmen at Alianza. I sent you a private message because we have 10 years worth of history. So I didn't know what you wanted me to share or not. But I think for my peers here on this call, I just want to say that it's really important that you gently push back as you advocate with DCF. And the only way that you can do that respectfully and gently is by having these relationships with the DV unit. A couple examples is that I don't accept their requests for information. We have our own confidentiality forms. A second example is that when I was realizing something was happening, Sue English immediately called me back. She strategized on what to do, and I 1000% believed everything she said she was going to do. And within 2 or 3 months, I noticed that we weren't getting referrals for the person causing the harm and the person who was being harmed. I mean, at one point, we were getting both of those referrals to our little agency. So those are just two of many examples.
You, Carmen, I was going to mention you.
Hema. Sorry, just realized I'm not on video. Hema, do you mind? Can you see me? It's Deb.
I can't see you, but I can hear you.
Okay.
Like, feel free, jump on in.
I think my video is on. Forgive me, I'm technologically challenged today. My name is Deb Fallon. I'm from Portal to Hope. So firstly, thank you so much for this forum. It's so terrific to be able to have access like this. And Susan, I wanted to tell you that I love listening to you because your story is so compelling, because not just you in your role and your team members, but we all can relate to sometimes feeling left out and a little bit isolated from things. So I so appreciate that. But I wanted to echo my colleagues' comments about your unit as well, especially as Michiko is one of our favorite people of all time. And I want to, recognize her work as well in that over the last 29 years, we just celebrated our birthday at Portal to Hope, where we have been able to work through challenging situations, certainly with the DCF, but the DV unit, and has helped certainly to, open the mind, so to speak, of administrators at DCF. And so we've been able to foster and really enjoy some terrific relationships with the DCF agencies that we're working with. So just wanted to say thank you for that.
Chico's one of our favorite people too.
It is recorded, by the way, Sue. Thank you for saying that. On the record. Yes.
I think one other thing that I'll say, so we had an opportunity back in 2017 up in the northern region with a handful of the programs up there near the Lawrence area, to be part of this research project that Futures Without Violence conducted. And it lasted several years, more than several, I think. And there was a lot of bumps and grinds to it. It was a lot of work. But I think that the thing that I will say, and I'm not expecting all of us to do this level of commitment, but part of being in this project was making a commitment of having very regular contact and meetings. Like the full representation from everybody involved happened once a month. There were also coaching sessions that happened several times a month. It was a big time commitment. So, and I don't expect that level from everybody, or when we couldn't do that with everybody. It's the state, but a commitment of time and FaceTime with each other to talk, not just like come together in a crisis moment, makes such an enormous difference. The relationships that were built during that time will be everlasting. Not just between us and the DV unit that were there and the DV programs, but literally in all of the individuals from the offices, because there were two offices that were primarily involved. And they still all talk about it, the people who are still there. So as we think about this, and I'm hoping this is going to be an ongoing dialogue and conversation, think about what kind of opportunities there are to be in those kinds of spaces. Because I think honestly, the first thing that started to happen was both, I hate to say sides, but both the DV programs and the DCF staff began to learn about each other, right? They began to learn about the sort of philosophical approaches in DV programs, also what they are faced with and struggle with side by side with the survivors and their kids. And the staff in the DV programs began to understand the breadth of things that a DCF staff person has to deal with on the daily. And it's not just DV cases, but DV specific cases is, staff that are lacking skills in the nuanced assessment of risk. Staff that have to literally walk into the homes of places that as a DV advocate, I would never have walked into, and what that is like for folks, along with the secondary trauma that they experienced and all of the other kinds of cases that they deal with. Just having that face-to-face time and understanding changed our conversations. So big proponent of relationship building, as you can hear.
I'm just going to say, when I first started in the unit, we did something very similar up in the Berkshires too. So we had done it with Elizabeth Freeman Center and the area office
project.
Yeah, and that was phenomenal. It really helped people to understand the challenges within both systems and then how to really work together.
Yep.
Yeah.
Well, this time has flown by. Adelise, I see your hand up, so I'll let you have the last question and then we'll close out.
I simply did want to echo I did want to echo what Sue Hubert was discussing. I had the privilege to sit as part of the QIC initiative, and it really did. And I have to say, Sue, your breath of like knowledge, because I even remembered when you broke down, and to this day, we still try to utilize, the family violence, community violence, intimate partner violence. And so just like you said, being able to also gain that knowledge of how she mentioned in the system, everything gets reported as DV, and then there's the whole program change that it's hard to alter. And so just systematically how hopefully, as you all have been mentioning, that within each system, as professionals, we are able to distinguish, what is intimate partner violence? Was this a one-time incident? Was this an accident? So having that, I guess, professional awareness and being mindful of that. And Michiko, when she got in, she reached out to us quickly. We had a team meeting, and Tammy and I have worked. Tammy has reached out when she has questions. So really having that relationship does help. It makes it easier for everyone, in particular, again, when we're advocating for our clients, having that relationship, being able to have that transparent, respectful communication is much needed.
Miss you, my friend.
Well, to close us out, I just want to reflect that this idea of, it's not a new idea by any means, but leaning into our relationships right now feels so necessary at a time when I think collectively as a field, as people, there is so much being thrown at each of us and the folks that we're working with and supporting in our own families and communities. There is a intentional way of pushing us into more isolation. And to the extent that we can counter that, that is a form of resistance to the current climate. And these efforts, while they seem on their face, let's get together, meet, know each other, understand each other, that can feel very far from these ideas of system transformation, and yet it's the first step, right? It is that work, because through solid relationships and trust, that idea of we can have each other's back and trust each other to take that leap to perhaps move in the direction that is towards what is most needed in that moment. That's something that is can only happen through this relationship building. And I'm just so grateful for this partnership, and really, really thank each of you for your time and everybody who came today to sit with this and strategize on what's next. It sounds like we're going to have a time to bring folks together, and
Great.
hopefully in person. That would be really lovely if we can make that happen, and begin that relationship building that may not be hours and hours of coaching that come forward, but could be the start of some kind of deeper connections between programs and you all. So thank you.
We welcome it.
Time. Thank you, interpreters, for everything, and really grateful to all of you.
All right. I will get you a couple of documents to be able to share out with the group.
Perfect. Thank you.
Thank you all so much.
Thanks, everybody.